what are the complications of diabetes? We know it affects a lot of the organs of the body, so just throw light on those complications.
One of the big ones is heart problems.
Okay.
So when you're diabetic, you're more prone to having a heart attack or a stroke. In fact, the major thing that kills diabetes is usually the heart problems, not even the diabetes. So when we're going to medications, I'll tell you some medications that can help.
Hello, everyone, and welcome to today's episode of Our Lives Narratives. I'm Annette. Thank you all so much for joining us today. For our returning viewers and listeners, we appreciate you for being here with us. Thank you for subscribing to our channel. We do appreciate you being with us on this journey. For those that are joining us today for the first time, you're welcome. We encourage you to subscribe to our YouTube channel. That way you continue to hear interviews by our guests that will continue to impact your lives and make them more happier, more healthier, and more inspired. Today we're talking about diabetes, an illness that impacts a lot of people around the world in so many ways. The World Health Organization has identified diabetes as a major public health challenge of the century. So to have this conversation today is a returning guest. He was here with us in the last segment and we had such an insightful conversation. We did talk about weight management and I got inspired and I took action, and I hope people that were able to watch that episode were inspired as well. If you haven't seen it, make sure to check out that episode when you have the chance. Our guest today is award-winning doctor, hospitalist. He's family doctor's expert, and he has a background in weight management, diabetes, and many more. So you all help me welcome Dr. Amanna. Dr. Amanna, you're welcome to this platform.
Thank you so much. Thank you so much. Like I said, your show is inspiring to a lot of people, and it's always an honor to be on your show, and I'm ready to just crack on. Let's awesome. Get going. Let's get going. Yeah.
And we appreciate you made a promise that you'll be back.
Yeah.
Every couple months.
Yeah, every couple months I'll be back.
And you're here, so we do appreciate your time because you have such a busy schedule. We do not take that for granted. And I want to share my, success story.
That's good.
From last episode. I lost about 10 pounds in, say, maybe 5-6 weeks doing intermittent fast. After we had that conversation, I'm like, I need to do something. I want to lose some weight and, take control of my health. So thank you for that episode. And maybe by the time you sit down again, you might not recognize me.
Who knows?
So thank you. Let's dive right into our conversation today. In order to set the stage, I would like us to talk about what glucose is and insulin. Of course, glucose, the energy fuel of our body, and insulin, a hormone that regulates blood sugar. So what is glucose and insulin? What is their relationship to each other?
Yeah.
And how do they impact diabetes?
So first of all, what is diabetes? It's a chronic condition where the body struggles to regulate blood sugar. And what is glucose? Glucose is a source of energy for us. You understand me? And then what does insulin do? It's a hormone produced by the pancreas. You understand me? And it helps the cells absorb glucose. Which helps us. Now, when insulin is not effective, what tends to happen is that glucose you now have glucose in the bloodstream.
Right.
So if it's ineffective or it's not available, you now have a lot of glucose in the bloodstream, and that leads to diabetes. Okay. I don't want to go too in depth because I'm not teaching medical students.
Right.
I'm not teaching medical doctors. This is for the general audience. So all you need to know is that diabetes is a condition that can lead to high blood sugars. That's what you need to know.
In layman terms.
In layman terms, yes, because, you know, at the end of the day, I'm not teaching a professional crowd here.
That's right. And that's what I like you're able to balance the information that you provide. Because obviously our audience out there, you might have medical doctors, your colleagues watching you, but there's a lot of people out there that are not in the medical field.
Yeah, and the aim of this podcast is for the layman, basically.
Right.
You know,
absolutely.
This is the majority of them. How many doctors do we have? I mean, they're nothing compared to the wide population.
Exactly.
You understand me? So this is for the general population and in layman terms. So
that's right. Okay, so talking about diabetes, we know there is, you know, a variety of types of diabetes. At the end of the day, it all boils down to how our bodies use insulin and glucose. So go through what the types of diabetes and how can somebody develop it over time.
So we have type 1 diabetes, which is like an autoimmune disorder where your own cells are fighting against some other cells, you understand me? And the cells that we have in our body are attacking the insulin producing cells, you know. And this usually is diagnosed in childhood or adolescence. Normally young people develop it. You understand me? And if you're type 1, you require lifelong insulin. Lifelong insulin. So if you're type 1, you require lifelong insulin. And then we have type 2, you know. It's more commonly linked to insulin resistance. It's in older people.
Okay.
You know, so, you know, you can have it in people in the mid-20s upwards. You can have it people in their teens. And this also can be due to various causes as well, which we're going to go into details. And then we have something we call gestational diabetes, which is diabetes that occurs in pregnancy.
Right.
The question now is, if you develop, because this is another question I'm going to preempt you, is if I have gestational diabetes, is there a chance I could have diabetes afterwards?
Right.
There is a strong chance, yes. Doesn't happen all the time, but there are some cases of people that have gestational diabetes. Later on in life, they have full-blown diabetes. Okay? And then there's pre-diabetes.
Right.
Which means you're not diabetic, okay? But you are not, your blood sugar levels are not normal. So that means you're in between. Now you have to, this is a group you need to watch very carefully as well. So I have patients, I diagnose them as being pre-diabetic, and I tell them what to watch out for. And I monitor them closely because from pre-diabetic, I've had patients, some of my patients who they're pre-diabetic, and within 6 months, they become diabetic. And there are some who are pre-diabetic, and they're pre-diabetic for years. You don't know which way it's going to go. But you have to be careful. You have to monitor them as well.
Is there, in terms of onset, what have you observed in your practice to be an average age where especially type 1 is diagnosed?
So type 1 is, like I said, a younger people. You understand me? I had recently, last year, I had a patient, mom, she brought her child and said, oh, he's always thirsty. You know, and thirsty is, you know, is one of the symptoms of diabetes. And I said, okay, we need to do, and he was about 10. I said, we need to do a blood sugar test and other things, you understand me? And actually, he turned out to be diabetic.
Okay.
And he was 10.
As early as...
So, so even earlier than that, you can have children earlier than that. So younger children, people in the early teens are more prone to be, it's likely to be type 1. Okay. And then older people, like people in the late teens, 20s, you understand me? Yeah. Now, there is some in cases where some children are actually not even type 1, but type 2, but not very often. Okay. So, but mostly children and adolescents are normally type 1.
Okay. So let's look at risk factors for diabetes, looking at age, race. Obviously, it's not all one size fits. There's different factors that impact, like age, right? So go through some of these risk factors. And, you know we have a broader audience of the immigrants, demographics watching when it comes to race? Like what are the risk factors?
One big risk factor is genetics, family history.
Okay.
So the lady that brought her son that I told you about before, she was diabetic. So if your brother, mother, father, sister is diabetic, or there is a higher chance that you might be diabetic. Okay. I've also had patients who have become diabetic, and I ask the question, do you have any relative in your family that's diabetic? Yeah, my mother's diabetic. So genetics is a big factor. Lifestyle.
Okay, that's a big one.
That's a big one. big one.
Yeah.
So if you're not doing anything, there's some people who like watching TV all the time. No exercise. I'm not gonna. There's a name they call them. I'm not gonna call them that
okay.
name. But people that like watching, don't do a lot of exercise and sit on their couch, eat a lot of snacks.
Yeah.
Sedentary lifestyle.
Right.
Because that can also lead to obesity, which is another big one. Can lead to is a risk factor for diabetes. Obesity is a big one as well.
Okay.
A big one for diabetes. You understand me? Poor diet. I love my chocolates. I love my processed foods. That's a big one.
Yeah.
So people that like sweets, chocolates, that's a big risk factor as well. Age is more common after 40 as well.
Okay.
So why I picked up diabetes in all ages. You understand me?
Yeah.
Teens, children, older people as well. In fact, a lot of people after 60 get diabetes as well. So I picked it at any age you can get it. You understand me? Hormone disorders as well can predispose some people as well. So these are the major causes. Now, what about racial? I know that kind of thing. Unfortunately, sorry to say this, guys. Being black, high risk factor. Understand me? Hispanics as well.
Yeah.
Hispanics, especially the Mexican Americans. Asians as well, very big. Because I'm from England, as you know.
Yeah.
I was born in England, and a lot of the Asians there had diabetes.
And what's
There's a risk factor. There's the predisposition.
Right.
They've got a high risk factor. You understand me? Genetic as well.
Okay.
And if you want to go to some statistics, let's talk about Black Americans. Okay.
It'll be nice to put things into perspective.
12.7% are diagnosed with diabetes. That's a big number. Compared to the white Americans, that are 7.5%.
Wow. And this is a variety of the type.
And then Hispanics, which is the Latin American listing, 11.8% have diabetes.
Wow.
But the American, because Hispanics, you've got those from Cuba, Mexico, from South America, but the Mexican Americans are at the higher risk.
Okay.
And then the gestational diabetes is more common in the Hispanics as well. Okay. And there's a higher risk as well amongst the Asians, like I mentioned before.
Yeah.
And even the slim ones.
Yeah.
And South Asians as well are particularly vulnerable to insulin resistance. So it is a big thing.
So some of these risk factors we can't modify, right? Like our age, our, genes, but there's some of them that we can modify, like the lifestyle, right? Lifestyle changes, rather. So I guess it's just important for us to choose a more healthy lifestyle, right? And then possibly, can it slow down how soon we get diagnosed if we work on those lifestyle changes?
So if it's genetic, you're eventually going to get it. But then what it could do is that your symptoms may not be as significant, as severe as when you're not doing anything about it.
Right.
So if you're very overweight, your symptoms are, maybe worse than somebody that was slimmer. Do you understand me?
Right.
In some instances, not all the time. You understand me? And it works a lot because, by the time, if you're obese and you lose weight, I've had people who, as they've lost weight, the requirements have the medication requirements have been modified in a positive direction.
Right.
So losing weight helps you understand me, in terms of controlling your diabetes as well. You understand me? Exercise is important as well.
Because this all help to regulate the your blood sugar.
Yeah. Exercise is important. 150 minutes per week. So we normally say 30 minutes a day. Now the question is, oh, doctor, I don't have the time to do 30 minutes a day. Why don't you do 10 minutes 3 times a day?
And find creative ways.
Now they say, oh, it's too cold, -50. Hey, hang on. What about your house?
True.
Walk up and down the stairs for 10 minutes. Walk around for 10 minutes. You can have your favorite podcast or your favorite music on while you're walking around for 10 minutes.
That's a great tip.
Every hour you could do 10 minutes. So as long as it accumulates to 30 minutes, it can help. You understand me?
Okay.
But like I said, if you're in an environment where the weather is good, you can go outside and do 30 minutes. I'm not saying you have to go and get a gym membership to do this. Walking is actually fantastic. So you can go out and take a walk for like 30 minutes. You understand me? If you're in a gym, that's fine.
Okay. All right, great.
And if you have a treadmill, just use a treadmill.
So you can basically slow down how soon you can, and even when you have it, all these, which we'll go into.
Yeah, so it may not slow down. It might not slow down when you have it.
Okay.
May or may not, but it can help the control. You understand me? It will help the control.
Regulate your blood sugar better. Yeah. So you can manage it.
Yes.
Okay. So talking about race, how, because of course, there's different factors impacting that, socioeconomic status, access to healthcare, and even our cultural practices, like dietary practices. Yeah. So as healthcare providers, as policymakers, how can we bridge the gap, narrow that gap of disparity amongst the race? Because we see more of the Blacks, Hispanic are being impacted, and there's other factors. Yeah, I mean, that's impacting that.
Number one, podcasts like this.
Okay, good.
Yeah. Your podcast, very
knowledge,
important.
Yeah,
because knowledge is important. A lot of people don't have the knowledge. They don't even know that this is wrong. You understand me? Like somebody is having crisps in the morning, crisps in the afternoon, chocolate in the evening, chocolate before they go to bed, sweets in the morning. They don't know that this may lead to them having diabetes. You understand me?
Right.
Somebody may not know that they have to exercise 30 minutes every day, 5 days a week. Somebody may not know that they need to eat more of lean proteins. You understand me? And fiber, whole foods. So they may not know. You know. So that's why these podcasts are very important, where at least you share the knowledge amongst everybody, individuals, and this can help. So knowledge is important. That's the first thing.
So seek for it. Go get it.
Listen to Annette's podcast. Listen to Annette's podcast. You see what I'm saying? That's important.
That's right. We're here to bring the best evidence-based information to you. Okay. Thank you for highlighting that. Yeah. So let's talk about signs and symptoms. So as individuals, what signs should you be looking at, or even for your loved ones, that, this might be a sign of diabetes, and how, as a healthcare provider, what kind of tests and tools do you use to diagnose diabetes?
So number one, let's talk about tiredness.
Okay.
So a couple of years ago, I had 3 people come to me saying they were tired. 3 different people coming to me tired. Now, when people come to me that they're tired, I do a full workup, because it could be anything. Tiredness could be lack of iron in your body. Tiredness could be due to thyroid problems.
Right.
Tiredness could also be due to diabetes. And then tiredness could be due to some other problems that you might be having, you understand me? So are you sleeping well? I mean, if you're sleeping at 2 o'clock in the morning time and you say, "Doctor, I'm tired," it's 7 o'clock. I mean, come on.
Exactly. Try.
Can you try and
try and go to sleep a bit earlier.
Try and go to sleep a bit earlier. I'm saying,
Yeah.
Oh, doctor, this movie, I like this series, the Blacklist, they call it, this series. I can't miss it. I mean, I want to try and cut it up by 12, but it was so interesting. I'm going to cut it up by 1 o'clock. Come on, man. You got to cut it up by 10 o'clock or 11 o'clock, man, and go to bed and then get ready for work. So sometimes that's a problem. But anybody that comes to me for tiredness, you should do a screen as well. Do a proper blood panel.
Right.
So for these 3 chaps that came to me, and it was the same month, the 3 of them came to me. Wow. Their complaint was tiredness. And I screened for that. I did the blood test. So the blood test you do a fasting glucose test.
Okay.
And you do a HbA1c. So the HbA1c measures your blood sugars over 3 months. That's very important. Yes, the fasting blood glucose level is above 7 on 2 different occasions.
Okay.
Then this is classified as that you probably got diabetes. You understand me? And then the HbA1c of more than 6.5 is diabetes as well.
Okay.
You understand me? So we send them for them, and then all three of them had diabetes. The same month they came to me. That was a complaint, tiredness.
Wow.
And all three of them had diabetes. So tiredness is a big one. So if you're tired, you got to see a doctor. You understand me? So that's number one. Number two, remember what I told you about the little kid that came with the mother?
Right.
Thirstiness. Being thirsty all the time could be a sign of diabetes. Having recurrent urinary tract infections. So all the time you're having an infection.
Right.
Kidney infection. You got to check. Is this a sign of diabetes? When you urinate, the quantity is bigger than usual.
Okay.
That may be a sign. Going more frequently to urinate.
Right.
That may be a sign as well. Losing weight may be a sign as well. Depending on which one it is, you understand me? Which type it is. So, yeah, you gotta, if you're having any of these symptoms, you gotta see your...
So bottom line, seek medical attention. Right?
Seek medical attention.
Because on your own, it may not be diabetes, but once you reach out, they can do all of the follow-up treatment tests.
Just once you have any of these symptoms, see a healthcare professional.
Right.
You know, so yeah, these are the symptoms,
that you should be looking out for. So keep an eye out for those. And if you have loved ones that are going through that, please
see your healthcare professional.
Encourage them to go seek medical help. That's all. I know our community, we don't like the doctors, but they're there for a reason, right?
Yeah.
Okay. So of course it's a deadly disease, and there's so many complications. What are the complications of diabetes? We know it affects a lot of the organs of the body, so just throw light on those complications.
One of the big ones is heart problems. Okay. So when you're diabetic, you're more prone to having a heart attack or a stroke. In fact, the major thing that kills diabetes is usually the heart problems, not even the diabetes. So when we're going to medications, I'll tell you some medications that can help you help prevent some of these things. So heart attack, heart failures are common in diabetes. Okay, that's related to the heart. Stroke as well is also related to diabetes. So as a diabetic, you have a high chance of having a stroke if you're diabetic. Okay, and then the eyes. The eyes, it can lead to blindness.
Right.
So as a diabetic, so all my diabetic patients, okay, I asked them, when last did you see the ophthalmologist, the eye specialist?
Right.
Get your eyes checked. Because it can lead to blindness. So you got to get your eyes checked at least once a year. And they will have a look at your eyes. There's a special instrument they use, and they'll blow up the images just to make sure you're not having any problems there. So that's very important. And then kidney. Diabetes can lead to kidney problems as well. So I always check the protein quantity in the urine. I must do that on a yearly basis on my diabetic patients. Now, there are some some of my diabetic patients who have had some kidney problems. Okay. And then I check them more frequently. Okay. You understand? So it depends on if you're just newly diagnosed and we check it and it's not too bad, then I don't check it. I check it every year, but I don't check it as frequently. The frequency depends on how it is with each subsequent visit investigation I do for you. Okay. So it's important to have that checked. You understand me? And then it can lead to peripheral circulation problems as well. You understand me? It can use to nerve problems as well. Some diabetes get numbness. Right. And this is the key thing. I want to mention it. Very, very important. If you develop numbness on your feet at any time, you need to see the healthcare professional straight away. That's number one. Number two, you should not be walking barefooted. I've had patients, unfortunately, who have had their feet amputated.
It can be serious.
If you walk barefooted and then you develop an injury to your toe, to the bottom of your foot without you knowing about it, it can lead to something bigger on, and before you know what's happening, it's too late. Right. Before you know what's happening, it's off.
Because you lose sensation.
Yes, you lose sensation. You don't even know it's everything. And then by the time somebody has a look at it, they'll look at it, oh my goodness, there's nothing we can do about this anymore.
to get into the habit of like assessing your feet.
Yes.
As
So
often
when I used to run my diabetic clinics, I would always look at your feet.
Okay.
I'd listen to your heart. I'll check your HbA1c, which is your average blood sugar over the last 3 months. I'll ask you about your eyes as well. I might check it as well. Just comprehensive.
Right.
You understand?
To keep, right?
And like I said, like you want to repeat it again. If you have numbness of your feet, see your family doctor or see your diabetic specialist, whoever looks after you.
Right.
But also make sure, do practical things. First of all, put on some slippers. And also get someone to have a look at your feet as well, because you might be able to see the back of your bottom of your feet properly.
Sure.
And if it's looks like it's an ulcer developing, you need to see somebody almost immediately, you understand me?
Yeah.
Like a family doctor, get to see him sooner rather than later. But even if there's nothing, they've said nothing, get some slippers. Because once you add them to your feet, you can't be barefooted again in the house.
Yeah.
You'll be using slippers.
Awesome. So bottom line, just be that habit of doing your yearly, monthly, quarterly exam. Make sure you're in contact with your healthcare provider, right? So that way, if anything develops, it can be addressed right away. So let's get into treatments.
Yeah.
So we've already touched on a little bit of like lifestyle change, right? You could add to it, and also what kind of pharmacological regimen as well that you do prescribe for your diabetes.
So the key thing is that we have different types of medication for diabetes. I'm not going to go into depth of it because it's for the layman.
Right.
We start with, so here, because of coverage, insurance, in Canada, we use, it's all about insurance. The insurance companies want you to start with metformin.
Okay.
Want you to be on before you can go on to some other ones.
Right.
Now, if you've had a heart attack or a stroke, then you could probably go on to another thing we're going to call regimens.
These are oral.
Yes. We're talking about orals now. You understand me?
Medication that you take by mouth.
Yes, medication you take by mouth. Yes. So because of insurance purposes, we normally start people on metformin, which is effective. It's effective. It's cheap. It does the trick. I have some patients. All they're on is just metformin.
Okay.
All they're on is just metformin. And it's been working for them, but everybody's different. So because this person, I have some people who are on insulin. I have some people that are on metformin and 2 other medications. So nobody is the same.
Right.
So if you say, oh, but my friend is on metformin, how come I'm not on metformin by myself? Well, because your body is different from your friend's body.
Yeah. So that's the key, right? The way glucose and insulin work, it will be different for every individual. Your lifestyle and all that. Yeah.
Yes. We've talked about so metformin is what I tend to use, and I start small. The key thing about metformin is to start with a small dose.
Okay.
So first of all, when somebody's newly diagnosed with diabetes, it depends on what the blood sugar is. Yeah. And then it depends on what your blood sugar is over the last 3 months. If your blood sugar over the last 3 months has been over 8.5, I'm going to start you on medication straight away. That's the guidelines, because there's no natural event you're going to do that's going to make you bring down your sugar levels. You understand me? Even if you watch what you eat, lose some weight, exercise, it's not going to bring. So above 8.5, I'm going to start you straight away on medication. But the key for metformin is to start slow. That's the key thing. I normally start with 250 or 500.
Okay.
And then after a week or 2, I bring them back and I gradually increase it. And then while I'm doing that, we're monitoring the sugar levels as well. You understand me? I have some patients who are only on 1 tablet of metformin. And I have some patients who are on more than 1 tablet of metformin. So it depends, you understand me? Now, metformin does have side effects. It can upset your tummy and it can cause some diarrhea. And there are some of my patients who don't tolerate metformin. So you got to be aware of that. But the key thing when you start metformin, you have to start slow because of the side effects it can cause. And some people, metformin might be the only thing that can do the trick for them. And some people, metformin may not be the only thing. Now we're talking about this management is about type 2.
Type 2, okay.
Because for type 1, it's insulin. There's nothing like metformin for type 1.
Right.
Okay. So we start with metformin. Now, you don't go beyond 2,000 grams of metformin because research has shown that above 2,000 it may not work.
That's per day.
Yeah, per day. Don't go. There's no point. Once it gets to 2,000, you start looking for another medication to add. Because research has shown that, above 2,000, but sometimes some physicians might go up to 2,500 occasionally, not all the time, but most times, once it's 2,000, that's it. They go over to the next medication.
Okay.
Now, the question is, what's the next medication? Well, it depends on what is happening in your life, you understand me? So it could depend on if you're very overweight. It could depend on your cardiovascular risk factors. The question is, would you go for insulin straight away after metformin? Now, I had a patient one time who was on insulin and metformin.
Okay.
Now, fortunately, if you've never been on medication before, we have other medications that we can use before you go straight to insulin. That was back in the old days. Back in the old days when we didn't have these intermediaries before insulin, people went to metformin. And I saw this lady, she came to me, joined my practice. She's on metformin and insulin. I looked at it and I asked her a few questions and I thought, maybe we could reduce insulin. Maybe we might be able to help her get off this insulin. You understand me? And then maybe she's looking at me, who does this guy think he is? You understand me? Getting me off insulin.
And just to highlight it for type 2, it is possible to get you off of insulin.
Depending on this.
Right, there's all factors.
And it depends on why you were put on insulin. Now, if you've been losing a lot of weight, if you lost a lot of weight, they've tried everything, you need insulin.
Okay.
You understand? There's some people, they're rapidly losing weight, blood sugar is not controlled up the roof, you need insulin, you understand me? But there are some people who, after metformin, they were put straight on insulin. Just because of the high blood sugar, there wasn't really any metabolic event going on.
Okay.
So in those kind of situations, there's some other intermediaries now that we can use before insulin. So when this patient came to me, he was on metformin and insulin, I said, maybe we could, use some of this stuff. So she was overweight as well. Okay. So I used Ozempic on her. And guess what? I got her off insulin.
Oh, look at that. Amazing.
And then even when she left my practice to a town that was more than a 3-hour drive, she would still come to me as a doctor.
Well, hey, I'm stuck with you.
And she now says she can now trust me.
Oh, wow. Look at that. You need to see results.
Thank you for trusting me.
There you go with faith.
because I looked at it, because the other drugs we have now, which are good products, you understand, which you can use. So the key thing is that would I jump straight to insulin after this thing? Well, if you're not having a major metabolic instance where you're losing rapid weight, your blood sugar is like up the roof.
Right.
No, I wouldn't. There's other things we can use.
Okay.
Now we have something called, I tend to use Jardiance.
Okay.
Jardiance, which is a good one. It's an SGLT2. I like it because number one, it protects your heart. So the people that are on Jardiance, research has shown that it prevents you from going to the hospital for having a heart attack. So it prevents you from having a heart attack, and also it protects your kidneys as well. So I like it as well. You understand me? So depending, some patients, the next one I could go on is to Jardiance.
Okay.
And if you're very overweight as well and got some cardiovascular risk, I might go to Ozempic straight away as well. The problem is coverage. Like in the past, they used to cover Ozempic here, but now some companies don't, because everybody was using Ozempic, so it became too expensive for the pharmaceutical companies. But Jardiance is a good one. I like Jardiance. So my second line could be Jardiance, it could be Ozempic, the ones I like.
Okay.
Now people are asking, what about sulfurias? Sulfurias like like glycoside and all those kind of things. Well, in the past, they used to use it, but the problem now, we realize that after a while, the effect wears off.
Okay.
So that's why we don't tend to use sulfurias right now. You understand me? And even when you go for conferences, because I go for a lot of diabetic conferences as well. And those are where you meet the guys that even write the guidelines for diabetes. You understand me?
That's nice.
And I also moderate some diabetic events as well.
So you're in contact with the latest research?
I hope so. It's always good to be up to date with the latest.
We're so grateful to have such a wonderful personality here.
We thank God. So yeah, so when we do so when we're doing, this is normally for doctors. So when we're doing like case reports, normally what we do is, we're going through cases, they go through cases and say, okay, this person's on glycoside, this person's on metformin,
right,
and the blood sugar is still not controlled. Is there anything you would do? And we say, hey, yeah, probably take the glycoside and put in maybe Emper. Oh yeah, that's the right thing to do.
Okay.
Because we know that the sulfurias, yes, they work, but the problem is that the effect doesn't last as long as the other one. So most doctors now after metformin don't jump to glycoside, the sulfurias. They'll go to like a SGLT2, like Jardiance, or they'll go to something like Ozempic. You understand me?
Okay.
So that's what I tend to do. So I'll either go to I'll either use Emper as my second line or Ozempic, depending on,
Okay.
Sometimes if your kidney function is not as good as I want it to be, I might go to Trajenta as well. That's another drug we can use. So it all depends. You understand me? Now, you have the key thing now about it is monitor.
Yeah.
So every 3 months, it's good to get your HbA1c done. So I have my patients, they do the HbA1c every 3 months.
Okay.
The good beauty about that, I know how they're doing every 3 months.
Right.
Because there are some people, if your blood sugar is consistently above 8.5, that's the average over 3 months, unfortunately, you might have to go on insulin. But like I said, that's after we've tried like Jardiance, Ozempic.
Other options. Right,
But if, for example, now we haven't tried some of it, we'll try it. Because I have some patients now who are just on Jardiance and metformin, and the blood sugar is well controlled. I have some patients who are on 3 of them. They're on Jardiance, they're on metformin, and they're on Ozempic. You understand me? And the blood sugar, or Mounjaro, and the blood sugar is controlled with that. And there are some of my patients, I had a patient one time, and I told him, he said, "Doctor, I want to go on insulin." I was okay. So, and then the next time it was high, and I said, "You know what? I've been tolerant with you. You know that. In terms of, you say you don't want to go on insulin, but look at your results now. They're consistently above, I think above 8 point something." I said, "You got to go on insulin, my friend."
Oh.
And then the guy says, "Okay, doctor," and he went on insulin.
Okay.
Because there's nothing I could do about it. It's all the good medications, all the intermediate medications, and your blood sugar is still not being controlled. Come on, we need to control this thing, and then you need to be on insulin. And then I started on insulin.
Okay.
And he's doing much better now.
That's good.
You understand me? And some of them will tell you, my sister, my brother had insulin as well.
Yeah.
But because your brother or sister is on insulin, doesn't mean you will be on insulin. Let's get that right. It doesn't. There's
already that fear of being poked so often, right? Yeah.
But we have other things now, which we shall go into.
Okay. All right.
I got you guys.
So what's your take on blood sugar testing? Like,
so this is
frequency.
So this is
because you need to be monitoring
so this is
that.
this is for like people that are type 2, you understand me? You don't need to monitor it as often. As if your blood sugar is well controlled, you don't need to monitor it as often. You understand me? Once every month is okay, once every 2 weeks. But this is the key thing. You should always have, if you feel dizzy, you need to check your blood sugar. If you feel sweaty, you got to check your blood sugar. So we give you signs of hypoglycemia. You understand me? You should be taught signs. Your doctor should tell you the signs of having a low. Because the key thing is the low is the ones that is the problem. Lows can kill you. You understand me?
Can we talk about the low, and then hyper?
Yeah. So the highs are less dangerous than the lows. The lows are the ones that are dangerous.
Right.
Because the lows can kill you. You understand me? So that is why, if we tell you before you start on any medication for diabetes, you should be given the signs of having a low.
Okay.
And then what to do about it. So you should have some snacks around. You should have some orange juice or fizzy drinks that can help you. There's some tablets sometimes you can take if you have a low. So you should all have this in your stock.
Have it at home.
You understand me?
Yeah.
If you're traveling, if you're doing a long distance travel, you should probably check your sugar before you go on long distance travel.
Okay.
You understand me? If you're going to exercise as well, because got to be prepared for all these things. But we'll tell you about all these. Your doctor should tell you about all these things and what to watch out for. You understand me?
Right.
But if you have a low, you should get a drink, get a sugary drink. You understand me? Or get some toast. Or get a tablet, a glucose tablet, that will help you. You understand me?
Yeah.
Yeah. This is for type 2 now I'm talking about, you understand me? And then we have kits as well, you understand me?
Mm-hmm.
Some people, we call it, some of the drug companies have kits that there's like a device you can put on.
Right.
Libre device, you understand me? Free Libre device that you can put on. And then you need to prick yourself.
Right.
You just scan it.
The sensor.
So they gave me samples.
Oh.
You know,
cool.
you know what I did?
No.
I said, I'm going to try this thing out, you know.
Yeah.
I put one on.
Nice.
And guess what? I would bath with it. And I traveled one time. Let me see if I can get stuck in the plane, you know what I'm saying?
Yeah.
And I actually went through the monitor without being caught.
Oh, that's good.
And it was amazing. You don't need to prick yourself. So when I used to run my diabetic clinic, I had the people that sell the Libra and all that kind of stuff in the listing. So they would show them, you know, how to use it.
Right.
They were not forced to buy it, you understand me? But just in case you wanted it, because there's some people who, you know, especially those on insulin.
Right.
The problem with the insulin is the needle.
That's the thing, yeah.
But with the device, you don't prick yourself.
So the Libre is kind of a long-term way of checking your blood sugar that prevents you from
just scan it.
So you have it every 2 weeks,
and it's not pain. So it's a small, because I put it on myself.
Okay.
It's not painful. It's not painful because I had it on myself. I went to try it out, you know, to see, okay, let me try it, and I could scan.
But the problem with that too is coverage. Maybe
yes,
right?
Coverage is
it's more convenient for people with type 1 because then you just have that sensor and you check your blood sugar. So as often as you're able to.
I mean, if you're type 2, you don't really need it. You understand me?
Yeah.
But for type 2, but for type 1, now if you're type 2 on insulin, then yes, it makes sense.
Okay.
If you're type 2,
right?
And then, like I said, there are some people, like I mentioned before, even after using the metformin, the Jardiance, or the Ozempic, and or Ozempic and Tradjenta, that the blood sugar is just that high that they need insulin, and then they have to go on insulin. Now, those ones, first of all, there's different things about this that we need to talk about. Number one is that before you give yourself insulin, make sure you have your food ready.
Right.
The mistake you don't want is, food is coming soon now. Let me give myself some insulin now.
Yeah.
Boom. And the food does not come in 1 or 2 hours. And all of a sudden you're found on the floor.
Not good.
With a hypo. So the key thing, before you give somebody, there are some insulins that you give, that you prescribe, that I prescribe, that you take it with food.
Right.
You gotta eat.
Right there.
And or if there's some before food, the food has to be ready for you. So immediately have it, even if you have to wait 30 minutes or whatever, within 30 minutes, it's there for you to eat.
Right.
Don't give yourself insulin if you've not seen the food available. Because the food will be ready in 30 minutes. What if the person forgets about you and the food is ready? And what if the food takes ready? Somebody wants some slow-cooked lamb. I want some slow-cooked lamb today.
You're in trouble.
You're in trouble, mate.
You might not end up eating that.
It might not be 30 minutes. Can you do my slow-cooked lamb in 30 minutes, love? If I'm ready in 30 minutes.
That's one thing I like about Dr. Amanna. He makes this information so fun and
So make sure your food is available.
Right.
So if you want to eat it, so it's ready, you put it in front of you, and then you ready it, and after you eat it, you understand me? Or it's ready, you can put it back in the microwave, you need to microwave or whatever, you understand me?
Right.
You got the food's going to be there. But the problem is, don't give yourself insulin without the food visible. That's what I would say. Because like I said, it's the hypos that can kill you. The lows can kill you, not the highs.
Right.
You know, so that's very important with insulin. So like I said, there's some people with everything they need. But the thing that if you can afford the sensor, it helps, because then even if you're on insulin, now with insulin, it's totally different in terms of monitoring.
Right. I was going to ask.
Before you give yourself insulin, you got to check your blood sugar, especially if it's active, because if it's low, you don't give yourself insulin if it's low. You know, although the doctor will give you all these guidelines about, so you should go to your doctor and they'll give you a guideline like, if it's low, you shouldn't, you know, what you should do. And, you know, so, but if it's low, you don't listen. Now, I had a patient one time, he doesn't like eating his breakfast.
Oh. And he's on insulin.
He's on insulin. And I say, don't give him any insulin if you don't take his breakfast, or don't do it. So the policy, he has a policy. If he doesn't eat, he doesn't get his insulin.
Right.
Because what you don't want is for him to have a low sugar, and you find him low.
Yeah.
But does insulin help? Yes, it does help. I mean, I'm going to be honest, it does help. But I've said it before, and I'll keep saying it again. Everybody is different. I have some patients that are only on metformin. I'm going to repeat this again. It's very important. I have some people that are on metformin and Jardiance. Those are the only two medications they're on. I have somebody that she's only on Ozempic. Only on Ozempic. That's all she's on. Because the Ozempic helps control the blood sugar, and then because we wanted to better control the blood sugar, we said let's reduce the metformin and just leave her on the Ozempic. And she's on Ozempic. I have some people that are on 3: Ozempic, Jardiance, and metformin. And then I have some patients on the 3 with insulin. So people are different.
Right.
So that your friend is on, and I have some diabetic patients who are not on any medication.
So you just monitor.
Yes. So those are the ones who the 3-month sugar level is high, but not high enough to start medication.
Okay, that's good.
So they're being controlled by diet. They watch their diet.
Right.
You understand me? So the question could be, okay, do you have diabetes who are not? Yes, there are some of I have some patients that are not, but I still monitor them the way I'm monitoring because they can flip anytime.
That's right. Okay. So it's type 2 reversible if it checks all the boxes.
You know what? By the time you're diagnosed with type 2, half of your pancreas is probably gone.
Okay. So that's a no. For the most part.
So if they come and tell you see this liquid here, it's going to reverse your diabetes if you take it, you're on your own, though. You're on your own.
So just working on those lifestyles.
Yeah.
Managing that blood sugar will help you have a better and more healthy life.
So the key thing, like I said, watch what you eat as well.
Yeah.
You understand me? Reduce your, don't stop your carbs, but you can reduce it. Your processed food, reduce it. Exercise.
Yeah.
What's
a typical regimen for insulin? I know some of my clients, they have 2, some of them 1, like long acting, short acting. Like so everyone's different too.
Everyone's different. I mean, so it depends as well. You understand me? So like sometimes we might just start with long acting.
Okay.
Yes, especially for type 2, we just start with long acting. And sometimes that's all some people need, just long acting. It does the trick. But some people, they need more than that. And then we, give insulin with the meals, you understand me? Which is the short acting ones, you understand me? So it all depends on the individual.
Awesome.
Understand me?
So basically, your regimen might be different. So what I hear from Dr. Amanna, continue that partnership with your healthcare provider.
Very important. So this is key, the key thing, you understand me? It's the regimen with your health provider. Now, not every family physician has extra qualifications in diabetes. I'm fortunate enough that I have extra qualifications in diabetes besides my being a family medical specialist. But not all family doctors have it. And therefore, they might refer you to see a diabetic specialist because they don't have the background I have. You understand me? And that's fair play. That's great. That's fantastic. You understand me? So you liaise with your family doctor and the diabetic specialist, you understand me? Now, because I have extra qualification in diabetes, it kind of helps me, you understand me? So I can manage most of them myself in-house, you understand me? But it's not the case for everybody.
To go get a family doctor. If you don't have a family
doctor, you gotta get a family. Very important.
You have to look around, get somebody. Because if you need referrals, you need your family doctor to refer you. Your eye specialist, your diabetic, doctors and all of that, right?
Yeah.
Okay. It's such a scary illness. It's, for the most part, sounds like it's lifelong. How, what take-home message or what advice or how do you walk along newly diagnosed clients? Because this is new.
Yeah.
There's lots of information.
Yeah. So the key thing is that, the key thing is work in a partnership with your doctor. Very important. See your doctor as often as he wants you to see him.
Okay.
Make sure you do your 3-monthly screen, which is the HbA1c, and also your urine test for the kidneys is all very important as well. Okay. Make sure you have your eye checked as well, at least yearly to 2 yearly. You understand me? Make sure somebody can check your feet as well. Develop any numbness anywhere, see your family doctor as well.
Okay.
If you feel your symptoms are getting worse, or like, let's for example, now you're urinating more frequently, or you're losing weight, very important. Losing weight and you're not doing anything to lose weight, see your family doctor or your diabetic, because someone that is not trying to lose weight and is losing weight and is diabetic, losing weight and diabetic is not a good sign. You got to see your doctor.
Okay.
Very important, you know? Yeah. And if you're on insulin, like I mentioned before, you got to make sure there's some food available there. Okay?
Awesome. Okay.
And then if you're on insulin and you see some lows, you go to see your doctor.
All right.
Visit your doctor. You might have a few lows. Go and see your doctor straight away, because then he can tell you how to manage. Like I have some people, they'll come to me and I'll alter the medication, the insulin, based on what it is.
Right.
You know?
Awesome.
And write it down. If you're on insulin, write down the doctor will give you like your pre-breakfast, pre-lunch. He'll tell you what to do, what to write, to give you a booklet. Write it down. So when you go and see a doctor, you can present it to him and he can see the trend as well.
Right.
And then some people, they have monitors now that can, the doctor can access it at the same time and see what trends are. You understand me? So, yeah, it's exciting times, great times. You understand me? But the key thing is partnership. It's a partnership between you, the doctor, and if the diabetes specialist is involved, diabetes specialist.
Awesome. Thank you, Dr. Amanna. I have a question from one of our viewers back in Sierra Leone. You might have covered a lot of them. He was asking, this is Alaji Alpha Jallo. He was asking about the cause of diabetes, which you already, went over. And also how they can limit this disease. So what message do you have for our people back there?
So, like in Africa, people like carbohydrates, a lot of, is it fufu or gari?
Rice and the starch.
So like now, this soup, have more soup on smaller portions of your carbohydrates.
Okay.
So instead of having this pounded yam, so big plates, pounded yam here, and your big soup. I
love my pounded yam.
Big soup here. Yeah. So you could cut it, the pounded yam, have smaller portions and have more of the soup, family. That's very important, And then the rice,
We like rice.
We like rice. You can cut down on the rice intake. You understand? You can still take the rice, but in smaller quantities, and have more vegetables on your plate.
Right.
Have more vegetables on your plate.
Because I was like, some of these tests are not available, but you were saying at least
the HbA1c should be available.
Right.
Yeah, so, it's a test that is very important, because that will tell us to me, it's more important than the fasting blood sugar if you're already diabetic, because that tells us how your sugar levels have been over 3 months, which is very important. The glucose test just tells us what's just happening, your blood sugar as of now.
Right.
And it might not portray the true picture over 3 months.
Overall, yeah. Okay. So ask your doctor if you're, a place like a country like Sierra Leone, make sure you're asking your doctor to do the hemoglobin A1C, which is done every 3 months. As Dr. Amanna said, that's one of the best marker to know where your blood sugar is at. So hope that answers your question.
And then there's another thing as well. We called it, sometimes if you're sick, or you're sick, diarrhea, all those kind of things. Sometimes the medication, you have to hold it off, like metformin, Jardiance, because it could affect your kidney. But go to your doctor, and he will tell you what medications to stop if you're vomiting or having diarrhea. Just discuss that with your doctor, and he'll tell you about it.
That's a great tip.
That was very important. I needed to mention that. Yeah.
Awesome. All right. Well, it's been another powerhouse conversation.
Like I said, it's a pleasure to be here. In this wonderful environment.
Awesome.
Now, can you get me some fufu after this? Some pounded yam, big pounded yam, some soup or something.
This is don't as I say, not as I do. Don't mind Dr. Amanna. Like, he is doing what he's preaching. So that's one thing we appreciate about him. Thank you. And I would encourage all of you out there for who, if you have this illness, like we already mentioned, a lot of people have it. I work with clients that they've had this for 30, 20 years.
Yeah.
Bottom line is how you manage your lifestyle, right? It's key. If you wake them up in the middle of the night, they know their regimen.
Mm-hmm.
So knowledge is power. Take control of your health. There's always new research coming out. So make sure you're inquiring from your doctor, getting evidence-based information, right?
Yeah, and I go to
empower you.
and I go to the latest conferences as well. You understand me? Like, there's another drug that we also use for diabetes called Mounjaro as well, which is also fantastic as well for diabetes control. Amazing drug as well. It's in the same category. It's similar to Ozempic, you understand me? But beautiful medication, you understand me? Now, just another thing I need to remember. Just remember that you can't you don't take Tradjenta and Ozempic.
Okay.
So if you're on Ozempic, you cannot take Tradjenta. Just something to mention. Okay. But just to mention that Mounjaro is also an excellent medication to use for diabetes, and I do use it as well. I do use it for my diabetic patients. You understand me? Okay. Mounjaro. But besides that, we wanted to mention the next topic we're going to cover.
Yeah, that's right. So take control of your health.
Yeah.
Key message: make sure you follow through with your family doctor and do all of those routine tests and examinations. And Dr. Amanna made a promise that he'll be here every 3 months. So expect that when we sit back, we will be looking at hypertension and stroke.
And stroke, that's the next topic.
We would select illnesses that are more prevalent in the immigrant demographics. So watch out for that next episode. He's always ready.
I'm ready right now. Can we do hypertension and stroke right now?
That's right. And by the way, Dr. Amanna has his own YouTube channel, Dr. GT. So check him out. He's got lots of information. So check him out on YouTube. Thank you all so much for joining us this evening. We do appreciate your time here, and I'm pretty much sure you've received a lot of valuable information. Continue to follow us on all of our social media platforms at Medan Productions on Facebook, TikTok, Instagram, and our YouTube channel. Make sure to hit the subscribe button and be part of this community. Until we see you again, as I always say, it's our lives and our story. Dr. Amanna.
Bye-bye. See you guys. Get ready for hypertension.
That's right. Bring all your family members and friends.
Yeah.
Good night.
Okay, good night. Bye.